Welcome back, Sports Medicine Project people. Hope you're all doing incredibly well, and welcome back to episode 2 with Dr. Stephen Kent. Now I'm here with Kelly, and Kelly,
it's
how you
really
doing?
episode 4 with Dr. Stephen Kent.
It is. Part 4. Well,
Part 4.
part 2 of syndesmosis injuries, which
Part
was an
2.
incredibly popular episode. Knew it was going to be. Probably should actually send him an email and tell him that. But yeah, really, really popular episode. I think people, do physios see it a lot, do you think? Why do you think
I was thinking about it. I have not seen a single podcast on syndesmosis injuries. I listened to quite a few physio podcasts.
Yeah.
And I just don't think it's one that I've really ever listened to, especially in that kind of depth with a foot and ankle orthopedic surgeon. So I think that's probably got some reason for it.
Yeah, something to do with it.
But yeah, and also I think it's common, or as we discussed, it's probably more common than it is picked up.
Yeah. Anyway, how you doing? How's things?
I'm pretty good. I'm probably better than you today. I feel like I've got some energy. You don't.
Yeah, I'm really tired, which we're going to get to when we talk about our highs and lows. But firstly, quickly, what we wanted to talk about on the podcast. Now, if you follow our Instagram and probably listen to a podcast as well, we very much don't promote crap, I would think. We very much try and be...
As far as we know. To the best of our knowledge.
As far as we know. Like gimmicky stuff, I feel. Or if we see gimmicky stuff, I'm definitely one... I probably called it out a lot more earlier, and now I'm not so much, because I'm just like, I don't care. I'm just going to create my own kind of content, I guess, or we're going to create our own content. But I would not talk on this podcast and promote something unless I did not truly 100% believe in it. And I'm talking about in a couple of weeks, which is very short notice, but in a couple of weeks in Sydney, the first course for the Future Health Network is going to be, which is the 31st of October. Now, I'm going to give a quick explanation of what the course is, which is basically talking about pain and performance. And generally, I think it's going to help people become a better clinician and also gain a better understanding. So it's a practical day, one day, designed to help people gain skills and confidence in dealing with pain in active populations, which is basically what we see every day. Most people, I would say 9 out of 10 people, come to us for pain. And if you're not a clinician listening to this, please just skip an extra couple of minutes in. But one of the things that it really does talk about, and it focuses on a couple of topics like communication and programming, but it talks a lot about critical thinking and also communication skills. So it's cheaper for students, it's a steal for clinicians, and if your goal, which I hope your goal would be, and it probably is if you listen to this podcast, but if your goal is to gain a better understanding of everything that relates to the complexity of healthcare, this is the course for you. Anything to add, Kelly? I'll be there. You'll be there.
We'll both be there. Just in the audience, just watching the big guns do the presenting. Yeah,
so it's Connor Glenhill, who's currently studying his PhD or just about to finish. I think he finishes this year. No.
I think, it's got a bit to go.
Yeah, and he's basically looking at the translation of research to clinical practice, amongst other things. There's Justin Smith, who you've heard on here before, Dave Renfrew as well, the pain weapon. So it's going to be an awesome, awesome day. And I think there's only maybe 9 or 10 tickets left. So definitely jump onto that. I know it's short notice, only in a couple of weeks, but I cannot promote a course anymore that I really do truly believe this will make you a better clinician. And I'd go as far to say is I'll give you a refund from my own pocket if you don't think it's a good course.
I think it's going to have stuff in it that you can apply from day one, like straight away. I think it's going to be one of those courses where it's a very applicable to every single person that you see to some extent. You know how sometimes you go to courses and you're like, oh, that's very, niche to that, specific person that I might see. Whereas I feel like this can be expanded to, pretty much every patient that you'd see, which I think is really valuable.
It's like the broader concepts, like how to deal with not knowing versus, the best treatment for Achilles tendinopathy, which I think the broader concepts definitely last a lot longer and I think make you a better clinician. I was talking to the students about this on Friday about, courses and things to do and what to look for and where to look for it and I guess what the courses offer. And I was thinking of a really easy way to explain it, but I think what these courses do, they somehow just tell you about the mistakes that they probably know that you're going to make. you know, as a clinician 5, 10, 15 years out, there's certain mistakes that you made as a new graduate or a first year, and you're like, wow, if I could explain this to people, I think that they would avoid making those mistakes and probably become better quicker.
I think mistakes are also important to make, though, as well. I think you learn more from mistakes as well, but then if you can avoid them, then that's also good.
Yeah, I think it's better to avoid them.
Yeah, but I think you can... Well, yes, definitely. It's better for the patient, for sure. But the mistakes that I've made with patients, I remember more than I remember anything that I've learned on a course, I would say.
Okay. And was that... Do you think that was from... Like, would you have been happier to have known that you were going to make those mistakes?
100%. Yes. I would have preferred to have avoided the mistake, definitely. But it's a good... I don't think you can say
I do agree.
that mistakes can't be made and shouldn't be made, because I think that's a valuable learning lesson as well. Yeah,
I completely agree. But I think a lot of mistakes you can probably avoid from courses like this, or maybe even have an understanding that they are coming and you're going to make them, but these are the things you can put in place to hopefully try and avoid as many as possible.
Yeah, okay.
Cool. We haven't really gotten to much of an argument, really, have we, lately? Compared to episode 1, where I was screaming at each other. Yeah. Anyway, so let's move on. Highs and lows for the week. What do you want to get started? You've got some exciting stuff.
Yeah. Another really exciting thing. Again, I wouldn't be encouraging this if I didn't 100% encourage.
Oh, get your own lines.
Whatever. But so my high of the week ties into another exciting announcement, and that is this week I was making a little advertising social media video for my private practice that I work at, Newcastle Performance Physio, because we are hiring. So I was making just a little compilation of videos that Joe and I had taken of patients. Yeah, a little montage. And it's just such a fun video, you know. You look back on it and you're like, wow, what we do is actually so much fun. Like, I love working here, and it's just great being able to do these awesome things with patients, you know, like patients deadlifting 130 kilos or front squatting, you know, 130 kilos, and taking them down to the track and doing running assessments and ACL rehab and practicing like change of direction down on a field. Like, I get paid for that. Like, it's just so fun. It's so great. So we were just making, a montage of all of these fun things that we get to do every single day to advertise for the fact that we are hiring. So if anyone is listening that would be interested at all in working for Newcastle Performance Physio, whether you've got experience preferably, but even if you are a student or about to be a new graduate, please send your resume through to dave@newcastleperformancephysio.com.au. I'm sure he'd love to tee up a time to have a conversation with you, and yeah, you know, if you're a fit, then welcome. Or even just message you through Instagram. Message me on Instagram. Or the page that you got, the Instagram page, Newcastle Performance Physio. Whatever. If you've got questions or anything like that before, you know, taking the leap and sending it to the big dog, more than happy to answer any questions that you might have about working at Newcastle Performance Physio. But yeah, very exciting. We're keen to get another physio on board. We're pretty busy at the moment, so it'll be nice to share the love around a little bit more. Yeah, and you guys, I mean, the montage looked awesome, and you see that athletic population, you've got a great environment there, but what I think is the most valuable, and I see that from working, you know, at the university, and I always tell the students the most important thing to see in those working environments is great mentorship, people with different skill sets and really good skill sets, which is at your work between yourself, Joe and Dave. Like, it's a great learning environment, great mentoring, and it'd just be an all-around awesome year. If you're a student or new graduate or whoever, I think you would love it. Hopefully more than a year. Hey? Oh, sorry, I meant like if you're a year out. Yeah. Just get in, get the stuff, get the knowledge, and get out. Get out. Yeah. Open a place down the road. Yeah, that's really exciting. That's awesome. Very exciting. Yeah. What's your low? I really couldn't think of any lows this week. I've had a really good week. Great patience. What about, I know a low for you. Are you going to mention it? Yeah, I know. I said, it took me a while to think about it. But I'm just tinkering on the edge of my of injury at the moment. I've had a few little niggles pop up over the last few weeks. The shins have completely gone away, so that I'm very, very happy about. Go the shins. They got this. However, the Achilles, mid-portion Achilles is now a problem. However, my care factor for the Achilles is just so low compared to the shins. It just doesn't faze me as much. It just warms up and it feels fine, you know? I'm like, tendon pain, I can deal with that.
Yeah, but those are the ones that, I think the Achilles stuff are the ones that tend to hang around the most.
They get a bit chronic, don't they?
Yeah. You've been wearing some heel lifts.
You've been isometrics.
You've been hitting the strength training. What's the go? Because isometrics aren't. I thought that was more. It's on the fence now whether isometrics are actually good for pain.
Isometrics have analgesic effects.
I think that's not been disproven, but I think that's up for debate now. I think Mick Hughes was maybe talking about that.
Any kind of movement is analgesic, but isometrics are a low type of load, so it often doesn't aggravate it. So if it's very irritable, or if it has been exposed to quite a lot of load, then that's a lower load option to make it feel better.
So just stretch, needle, cupping, get in the boots. Yeah, so what are you going to do? What's your plan of attack?
I'm just going to manage it, I think.
Sweet. Is that what you tell patients?
Deal with
the plan is to manage it?
No, I'm going to wear maybe heel lifts for the next week or so. I'm going to maybe probably not run heaps fast or do like hectic hills.
Yeah, sweet.
And otherwise just carry on. I'm probably not going to increase my volume too much more is the other thing that I thought of until the marathon. I think finally got up to about 60 Ks this week, and I'm happy to just stick at that. I just think that for the sake of actually getting to the start line and being able to run the marathon, I'm pretty happy with just staying sort of where I am at the moment. And I think that will be enough to just keep it at bay.
Yeah.
Yeah.
Sweet.
What do you think about that?
Oh, no, I think that's a good idea. I like the unload, offloading part of. I think that's fun with heel lifts and shoes and things like that. But you can't go past getting into the strength training. The only thing that I think you should do, and for anyone listening to this that has a partner in healthcare or tries to treat your partner, don't even bother. You just can't do it.
We don't do it very well.
We hate each other. I feel like I'll go sleep in the shed if we talk about healthcare. We're trying to give each other advice. Talk about everything else, but I think you should be doing more strength training more frequently.
I do it at
work.
work.
I mean, calf raises 3 to 4 times a week.
I do them when I have a little gap in the day at work. I'll go into the gym and I'll do some calf raises on the Smith machine. Yep, 30 kilo single leg calf raises off a step.
All right, well, you didn't tell me that. So maybe you are doing all the right things. I would avoid heels, actually.
I think I'm not going to avoid them. I'm just not going to increase the amount that I'm doing. And I'm probably going to wear my my carbon plated shoes a little bit more, maybe.
Why can't you say what the shoes are? Are you trying to make just in case we get a sponsor?
There's two. Well, I wear the Sauconys as well.
Oh, okay.
Even though they're nylon plated.
Yeah, they're like 450 Ks. Those things are busted up.
No, they were good today.
Kelly doesn't like to wear Vaporflies, and I have no idea why. She hates wearing racing shoes. Yeah, we need to figure that out. I think you just need to wear them in a little bit because your foot's too cavous. I think.
Too unstable.
Too unstable. Yeah.
Yeah, we've been fighting for the last 72 hours about what shoes I should wear for the marathon. I'm indecisive. Blake keeps trying to give me advice, and I keep saying no to everything he says. So if anyone has some real advice, let me know.
Yeah, I completely agree. I would be happy for my mum to give you advice at this stage because you won't listen to me. Anyway.
Your highs and lows, go.
Yeah, so the high of the week, I had a patient that had been sent to our practice with a very, very long history of plantar heel pain, kind of medial inferior to the malleoli pain. And, we treated it as a kind of a plantar heel pain. And, as seeing, and easily the most common thing that I would see clinically is plantar heel pain, and seeing a lot of them now, at the practice. I would say maybe 3 or 4 a day, a very high volume of musculoskeletal patients.
Do you get bored of them?
No, they're always, because, they're all not the same. Some of the treatments are pretty similar, but I really enjoy the person attached to them, because generally it's active people. They're runners, they're trail trail runners. They've got these weird, incredible jobs, like they drive that guy I was telling you about, that he flies out on a helicopter to the big coal ships and then drives them in, like just cool things. Anyway, so I did what I would usually do and explain things as I usually would, and things didn't get better. There were probably times where things were worse, and saw this person this week, and I felt really confident, explaining how pain is complex and injury is complex, and we'll generally follow a spectrum of treatment where down one end, down the right side is surgery, and down the other end is basically doing nothing. And we logically start at one end and work our way down. We don't jump down to surgery in most cases. So I was basically saying I'd done everything that I could, and in most cases things get better, usually pretty quickly initially, and then they kind of taper out, and then they get better that 100%. And I think that I've probably not much more I can offer you, and I think it's probably best that you see someone else with a different expertise, and that was one of the sports doctors. And I just felt really confident explaining that to him. I obviously felt bad that I wasn't able to help, but I was really happy to send him on to someone else, knowing that I'd done everything that I could. And I would hope, and I think, and I mean, he's going to be seeing one of the doctors, but I think he was happy with that we tried everything, and he was seeing the next person. And I explained to them, it's always easier for us as practitioners, because we see people in half an hour blocks once every couple of months, or once every week, or once a month. They're the ones dealing with pain. They're the ones that are frustrated. So sometimes it can be easy for us to say, it's fine. I don't think I can go and see someone else. And they're like, another person I've got to see. But yeah, it was just felt confident explaining that, which was nice.
Yeah, I think a lot of it as well, because you do see that plantar heel pain so often.
Chronic cases typically as well.
That you'd know that you'd be more confident that things are going to improve with certain interventions, whereas 2 years ago, when you hadn't had as much experience, maybe you're thinking like, it might be something that I'm doing, whereas now you're like, I'm pretty confident that I know what I'm doing, and if it's not getting better, then they're handing over or referring on is the best way forward. And
sometimes I've sent people off and they've actually come back to me because like, no, and the other person, whoever, and generally it's a specialist, they're like, no, you were doing the right thing, we'll just see how it goes and give it a little bit more time, which I'm happy to do. But I'm definitely now so much happier to bring people in earlier into the, I guess, the treatment group, and get their ideas and their expertise, which I really, and we always encourage new graduates and students and other clinicians to do that. It's such a backstop to stop you from missing things, or from seeing patients for 6 months when they probably should have seen someone else so much earlier. Yeah. And the other high, thinking, and I wanted to explain this on the podcast, and I haven't thought about it too much, but talking about different tissues and what tissues need more load compared to other ones, and at what stages. So things like a bone stress injury or a nerve neuritis or irritation, they typically need a little bit more of a cuddle early on and don't need as much rehab. So not everything, the saying of you can't go wrong getting strong, that definitely holds true for most cases, but there's certain tissues that don't need to be strong inherently by resistance training. So tibial nerve irritations, Backus nerves, sciatica, I'm thinking. No, not sciatica. You got to get strong with that. Yeah, initially in the early stages.
Well, sciatica is just such an umbrella term that means so many different things. So more often than not, exposure to movement and some sort of light loading is recommended.
Yeah, okay. Because I'm thinking of
the worst thing that you could do for a back is not move it.
Yeah. So, and I'm thinking like general movement is fine, but I'm meaning like actual specific rehab. I don't think that there's certain tissues, and just based off the tissue's physiology, I don't think they need as much strengthening conditioning early on. Like for a Baxter's nerve, or if someone's got a stress injury to their bone, they don't need rehab to start with initially, or as much rehab. Definitely movement, but it's more cuddling and offloading initially, compared to, say, a tendinopathy.
Yeah, I don't agree with the sciatica one, but for the others I do.
Yeah, that kind of popped into my head. Sciatica's not a thing anymore, hey?
I guess you'd probably call it more like radicular pain.
Generalised radicular pain.
Well,
yeah, maybe we should talk about sciatica one day.
Yeah, we can.
Anyway, so yeah.
There's so many different things that
good.
people call sciatica anything the way they've got pain that's going down their leg is sciatica to people, but it doesn't, I don't know.
Yeah. You know what? I did it. I should have just stuck to the foot and the ankle when I knew. I said sciatica because I thought it would sound cool. Hey, legally I can treat to lower back.
Well, I wouldn't be going to see you for a lower back after that.
Hey, I've had to 2 people these days. One, and I've sent them both to someone else straight away. Someone for their hip. You've given them like a
brace, a back brace.
Unloading
them.
Yeah. Don't move.
Don't move.
Don't move.
Put a back brace on.
Your hips are out. Let me get these needles in there.
Don't lift anything. You'll bust. You'll break.
Yeah, and lows today. Fucking hell, I did a long run today and I'm tired. I'm real tired.
Stitched yourself up with that one.
I tried to.
I just don't have the sympathy for you today.
So my program is getting to the end and I've been doing some long runs. Did 28 last week, 30 today. And I've been reading a lot about, watching a lot of Steven Silas work, and I'm going to get a coach after Queenstown, definitely, if I still enjoy running after that. But I was like, it would be cool to do a workout. I would do 10 easy, 10 at marathon pace, and then 10 easy. And then I did the first 10, and then I did the second 10, and then I had a bit of a yarn to these runners, which was fun. But then the last 10 were fucking horrible. I hated it because I was like, did that quick effort, and I should have just kept going, and I changed my shoes. Should have just kept going, so it wasn't enjoyable at all. I hated it, and it then made me really tired. I had like an hour nap, and I'm so keen to go to bed tonight. Grumpy. And I don't get. I'm grumpy. I'm just like, I just can't imagine. I don't know what I can see now why people keep their long runs to 21k generally if they're not training for a marathon. And we were out there till like 10:30.
It was hot.
I wanted to be running by like 5:30, and we just weren't.
I feel good after. I only did 24k's, but you know why I think I feel good?
That could have been a high for you.
Yeah. That definitely was. Actually, you know what the best high is? The song "Omen" by Disclosure. Listening to that at 23 or 22 kilometers, I was just singing. I didn't care. It was so fun. But what was I going to say? Oh yeah, after I finished, you were still running, and so I just walked up and down.
Active
recovery. Usually I finish a run and I get in the car or I sit.
That's not active. It's just recovery.
I'm just not sitting is the thing.
That was a functional active recovery.
It helped. And I also swam in the ocean today, which was also good.
That was a good functional active recovery swim.
It was very dumpy though. It's hard to get the timing right to get in and out of the ocean.
Good. Right, we're talking about oceans. We better wrap this up.
All right. Dr. Stephen Kent.
Enjoy episode 2 with Dr. Stephen Kent. And if you guys have any questions, case studies, topics that you would like discussed, or anything at all, or you would like to have a guest discuss that, please send them through. And if you want to be a better clinician, if you want to be a better person all around, couple of weeks, Sydney Future Health Network, reach out. It's on our Facebook group, or send us a message on Instagram and I will send you the link.
And if you want to work at Newcastle Performance Physio, shoot me a message or email Dave.
Yeah, sweet as guys. Have a good week. I'll be sticking to running. That's why running's the best. There's no one hit me from the side or my ankle.
Well, you never know. If you're down a hill or something like that, slip like wet grounds. Someone treads on your leg as you and rolls it outwards. It can happen.
Right. Come on, mate. Give me a little bit of
likely.
I'll be strapping my ankles. I'll be casting it, bloody orthotics and everything over the top this afternoon. And moving a little bit more to the rehab side. And I know Kelly, like you've definitely rehabbed way more syndesmosis most injuries than myself. I mean, what do you like to see from clinicians post-operatively, and then also when they've seen you for an opinion and you've said, no, I don't think this is a surgical case, go back and see the physio?
Or not even post-operatively, even if it is one that is managed conservatively. Or not conservatively, non-operatively.
Non-operatively, yeah. So typically the ones where we're treating non-operatively, they've sort of got a single ligament injury, so it's got an AITFL injury, or we were worried that a 2 ligament injury, but so the crux that 2 ligament injury is some are unstable and some aren't. So some have excessive movement and some don't. The only way you can tell that is under an arthroscopy. So we have to actually take them to an operating theatre and test it. So there'll be some that actually have an operation, but they don't get any stabilisation or fixation. And then we can treat them just like a grade 1, essentially. They're probably going to take a little bit longer to recover, but you can rehab them simply. Typically, the good news is for syndesmosis, whether they're operative or non-operative, is that the rehab's actually pretty good, pretty simple. It's not terribly complicated. You're trying to reduce that amount of sort of external rotation, dorsiflexion movement in that sort of 4 to 6 week period, essentially. But majority of the time, say for a grade 1, I might let them start weight bearing in a boot by say the 2 week mark. and try, if we're really lucky, to get them out of the boot somewhere between the 4 and the 6 week mark. And they can sort of they can definitely start range of motion from the get-go, but they can really start some sort of ankle strengthening and proprioception work from that sort of 4 week onwards. Now, the time they get back is a bit variable depending on the sport and what they do, but typically they will take longer to rehab than a typical ankle sprain. So whilst it sounds like we're pushing them through based on that rehab, they tend to take longer to get back than a low ankle sprain. So funnily enough, I think I'm sure you've seen the post-surgical ones, Kelly, that after surgery, they tend to rehab pretty well. They're pretty quick. That's what I found. Yeah. So
100%.
I don't think there's any papers that say they get back to sport quicker, but I presume they should, based on just what you see from a rehab perspective. Usually you're more confident that it's stabilised. So you're usually happy for the physio to push them.
I also wonder if sorry to interrupt you. If the group that they tend to happen in are typically more the sporting people rather than people that I don't know, maybe that has a factor in that as well.
They are, and I've definitely seen non-sporting people take a lot longer, a lot longer. You're right. They're usually motivated people. They're usually trying to get back to play. They're usually aware of the injury because they've seen their colleagues have it. We're typically talking about rugby league players, I think, and union players. And so they know they can get back to it in a certain time frame based on what they've seen for others. And so they know they can push it after surgery and they're motivated. So you're right. Yeah, you're absolutely right. The other thing is, though, is that the literature is a bit funny on it. So, like, I know from following the NRL physio on Instagram, where he puts up how quickly the NRL players get back from their syndesmosis injuries, and it used to be sort of 12 weeks, and now it's almost down to about 6, which is that really
post-operatively?
Fast. Really, post-operatively. Yeah. But the literature would say something different. So they've looked at professional soccer players and treated by a world-class organisation that does a lot of syndesmosis injuries. And I think the average time to return to play in the professional soccer players was about 100-something days, something like that, which is a lot longer than what we see in the NRL. Now, it'd be great for me to sit here and say, the surgeons are better, but they're probably not. Physio is probably equivalent at least, and they're probably getting a similar amount. So I just wonder whether it's the expectation that's different. Because I would have thought the rigors of your ankle playing rugby league for that type of injury would be worse than a soccer player. Even though soccer player is running more minutes and probably pivoting a bit more, your average rugby union player is getting themselves constantly into positions where their ankles are being rotated, particularly nowadays as opposed to, say, 15 years ago. There's a lot of wrestle in there. There's like third man in. There's a lot of tackles where they're really twisting. But we don't see a lot of, this is just anecdotally, just from watching the NRL, I don't see a lot of repeat offenders in terms of repeat injuries. There's one or two that spring to mind. Funnily enough, they probably play for Newcastle, but but there's not many that I can think of that keep having the injury.
Is that in that absence of a fracture as well, or?
Yeah, they're sort of different beasts, I guess.
Yeah.
They're different. They're much the same, and the mechanism's the same. Fractures will take longer in general. It's usually a bigger operation, more dissection in terms of bigger cut. There's more hardware left in the patient. Usually it's a bigger rotational injury. There might be rather than just a syndesmosis, there's a fracture, so another injury. So we don't typically see them come back and do another fracture, but definitely their rehab will be. So the study I was talking about, the soccer players, and then talking also about the NRL players in terms of that 6 weeks, that's just purely soft tissue syndesmosis injury. That's not a fracture. I suspect the fracture will take at that level of play, the best I've got back, that's an NRLW player, was about 10 weeks with an ankle fracture with a syndesmosis. Yeah.
So you think of just like healing time frames, like 6 weeks is very quick just in regards to that. But yeah, I don't know. Oh yeah.
Yeah. No, I agree. I suspect they're relying on their tight rate at the 6 weeks. That's typically most giving the tight rate. That's the fixation. So it's like
I was just about to. My next question was, can you talk much to the surgery? Not in the sense of we want people listening to this to be educating their patients on the surgery, but just so they have an understanding of the different types and maybe when one's more indicated than another.
Yeah, so in terms of indication, in terms of what's put in, it really purely is surgical preference. Okay, so surgeons will argue one way or the other and why they do it and whatever. The literature would say that, so we're talking about basically either putting in a screw or putting in something called a tightrope. And a tightrope, basically both surgeries involve you drilling holes from the fibula, so the outside portion of the fibula, all the way through the fibula, then all the way through the tibia out to the other side of the ankle. And then putting in some sort of device that basically sucks the fibula to the tibia and stops it from moving excessively. Okay, so that can be either a screw or a tightrope. And the tightrope is basically a strong synthetic fiber that sits in the drill hole. And then on either side of the fiber are two metal buttons. They literally do, they look like buttons. And they basically squeeze the two bones together. Okay, now they both work. We know they both work. The advantage of the tightrope is it usually stays in forever, whereas screws can break, and sometimes some surgeons would remove them routinely. Other surgeons say just let them break and leave them in, and there's some evidence to say leaving them in is okay. I've done a mixture of both. Typically, surgeons will evolve over time, so I actually started off putting a lot of screws in. I put more tight ropes in now. In certain big patients, I'll put a screw in first and actually exchange it for a tight rope a certain amount of time later. Because basically the difference between the hold of the two is that the screw actually holds the fibula dead still, essentially, whereas the tight rope allows a bit of micro movement there, which is more physiological. But in some, but basically the literature would say that both of them work. So there's not a right or a wrong answer. So if you've had a patient that's kind of got a screw that's not wrong and it'll still work absolutely fine and work very well, and you have a patient that's had a tightrope, then same deal. So and foot and ankle surgeons have been arguing about that for like 8-10 years basically, and there's been lots of RCTs and studies, and basically both are right. It's really whatever the surgeon wants to do that works for him basically, but they'll both work essentially. Okay, as long as the surgeon has a good reason.
Is there much to like bracing and things like that post-operatively? I mean, like, can you brace or wear any kind of brace around the ankle or around that area of the leg?
In terms of what, treating them non-operatively or preventing the injury?
I mean, that definitely won't be able to prevent. I wish. I mean, only orthotics prevent injury, but that's another topic.
Yeah, of course. Absolutely.
Like even like post-operatively, or if you have managed it in a non-op situation, is there anything to wearing braces? Like, do you ever recommend that? I mean, is it just more of a proprioception thing, or?
I've recommended them for low ankle sprains, absolutely, because there's good evidence to say they reduce the incidence of low ankle sprains by a considerable margin. I think it's like 75% or something. I don't know the literature on high ankle sprains.
I don't know about high ankle.
Do you have
I tend to. I mean, but based off low ankle sprain, taping for a high ankle sprain, I'd probably just like reinforce the like the anchor a little bit more up the top is what we kind of tend to do, like squishing the tibia and fibula together a bit more. But
I know from a symptomatic. Sorry, Kelly.
Go on. And I guess like there's no harm in taping someone up to 6 months after an injury, after a higher ankle sprain, which is what we tend to do for a low ankle sprain. So maybe.
No, true. And I know symptomatically patients, anecdotally, they feel better with taping around the syndesmosis. So I don't think it's not that you're right, Blake. It's not going to prevent an injury. You know, typically they're quite severe injuries if you watch them on the videos. I think definitely as part of your non-operative treatment for, say, a grade 1, then I think taping it is absolutely advisable, probably for sort of 3 to 6 months, particularly returning to sport or training, because you really are trying to limit that external rotation abduction movement. So the more you can provide that sort of buttressing to the fibula, the better. Although we sort of know from taping that after a period of time, it's less effective because you sweat, you know. So I think I do think it's useful. How long and how beneficial in the long term it is hard to predict. I don't think necessarily for once they've had surgery, I don't think there's much real benefit, because if they're not being held by whatever that's been put in during surgery, then
Depends how tight you do the tape.
That's a problem, right? So
yeah.
So that's one other thing I didn't mention. The one thing with the screw is you can surgeons in about 30 to 40% of cases can mal-reduce the syndesmosis with the screw. So that means they put the fibula in, put the screw in, looks great on an X-ray, fantastic on an X-ray. But if you got a CAT scan and looked at where the fibula is sitting next to the tibia, it might be being held too far at the front, too far at the back, or too far away, basically. Yeah. And that has long-term implications. So typically when I've been putting in screws, I actually look at the syndesmosis and putting it in to make sure it's in the right spot. But that's been the typical problem with screws. The tight rope's actually been shown in a lot of cases that they'll sort of slip the fibula into where it should go as you're putting it in. Not certainly if you drilled wildly off the track where you should be, it wouldn't. But that's one advantage. That's the other thing. So patient, the only caveat I'd have to say, if you've got someone that's had a screw for a long period of time, but still very much having syndesmosis pain, that is one thing to potentially think of. Although it'd be a very brave person to then run off to the surgeon and say, "Hey, you put this in the wrong spot." But but that's something to consider in a patient that X-rays look perfect, and screw looks good, but
go from there. All right. Well, any parting words before we jump on to the listener questions? Kelly, did you have any other questions?
I mean, I was interested in going into the different like trimalleolar fractures and the different types of sort of syndesmosis injuries, if we've got time to go through a couple of the common ones.
I do. I was aiming for a 2-part podcast, so like the longer you can make this go, the better.
Yeah. All right. Well, you guys chat because I learned so much. I'm not going to have much input.
The one starting with M that I am too bogan to pronounce.
Maisonneuve. Yeah. The French one. Just so the French one. Yeah.
The French one.
So what are you guys actually talking about? Tell me.
What are we talking about?
Yeah.
Take it away.
Yeah.
Okay. Well, I guess, look, when we're talking about ankle fractures, I guess I'll try and make it really simple. Like when people talk about unimalleolar, bimalleolar, trimalleolar fractures, all we're talking about is how many bones or how many breaks there are in the ankle, right? So, uni is 1, bi is 2, tri is 3. Okay. Typically, what I would say in general is that you can have a syndesmosis injury with any of them, but they're more likely, say, if you've got broken more than one area of the ankle. Okay, it's going to be a bit confusing. So basically, like we're talking about the fibular fractures. People would be somewhat familiar with the Weber classification as to what level you break it at, being the A is below the basic level of the joint or level of syndesmosis, B is at the level of the syndesmosis or at the level of the joint, and C is above that. So a Weber C in a fibular fracture is almost always associated with a syndesmosis injury, and that is actually why it gets operated on majority of the time. The only time you get a high fibular fracture where it's not got a syndesmosis injury is if it's a direct blow. So if someone whacks you with like a tire iron or something like that into the leg, that's not a syndesmosis injury, that's just a fibular break. It'll be fine. It'll heal with time. Okay. But if you've got any rotational injury with a fibular fracture above the level of the joints, that will by rights have a syndesmosis injury with it and should not be treated non-operatively. It should be treated operatively unless the patient, can't have anesthetic or has great risk for some other reason. Okay. When you go further down, which is the Weber B, which is at the level of the syndesmosis, a percentage of those injuries will have a syndesmosis injury with them. Now, a marker of that on an X-ray would be what we call talar shift, which essentially means the talus moves with the fibula laterally, and as a result, there's an increased gap between the talus and the tibia on the medial side of the ankle. Okay, it's called, the medial clear space, basically. It's the medial gutter of the ankle that opens up. So you need a weight-bearing X-ray really to tell that. But that's, you'll see it in some with the Weber B. That'll be what you see on X-ray. You see the fracture, but there's a gap on the medial side as well. That would need to be treated with an operation. Okay. In saying that, a percentage of those Weber Bs that look fine on X-rays and the fracture looks not that displaced may still have a syndesmosis injury. And really, in terms of working out whether it has to be investigated further or whether it needs surgery, it's probably best looked at by an orthopedic surgeon. There is a bit of conjecture around that as well. Typically, what I do is I'll actually CT scan them because sometimes it's not obvious, but there's a little posterior malleolar fracture at the same time. And that means there's been a real rotational injury, and usually means a syndesmosis is involved, and I'm much more likely to fix the ones that got that extra bit. But just as a general rule, if there's a Weber B, so a fracture at the level of the syndesmosis, probably best to refer on to someone else with that.
That's good advice.
Really good advice. Okay. And then a Weber A, so below the joint, no, it's not going to have a syndesmosis injury, so you do not need to worry about that in that regard, and those patients don't usually need surgery. Okay. So that's actually unimalleolar fractures in a small nutshell associated with syndesmosis injuries. Basically, if you've got any more injuries, so bimalleolar, so typically that's a fibular fracture with a fracture of the medial malleolus, so the tibia on the medial side, big toe side, that's probably going to have a syndesmosis injury. And if you've got a trimalleolar fracture, meaning that usually you've got a break of the fibula, what's called the medial malleolus, so on the big toe side, and a break at the back of the tibia, called the posterior malleolus, they're probably typically going to have a syndesmosis injury as well. Okay, but typically, as surgeons, we're more often than not treating those fractures, treating the patients that break both with an operation most of the time, and we will usually screen that patient's or look at that patient's syndesmosis injury when we're in there. We actually can go and check it out on an X-ray properly, or look at it ourselves. And funnily enough, the X-rays we get screening it now are probably not that accurate either, so I always go look at it. Okay, like I literally just get an instrument, I poke it between the fibula and the tibia and pivot. And if it moves, that's bad. If it doesn't move much,
just have it written on the whiteboard.
Okay.
Move equals bad, not move equals good.
Yeah. Right. Okay. But basically, just got to think. Look. Okay. If more than one area is broken, there might be. So probably need to refer on. Or if there's a Weber B or Weber C to the fibula, yeah, it probably needs to be referred, because probably has a, well, C's definitely and B's maybe have a syndesmosis injury. Okay, so unless you've got a Weber A, basically that one's the one that's not going to have one, but everything else you'll be at least worried about. Okay, and probably either needs a higher opinion or higher level imaging. Okay, and then the nasal nerves.
I was just going to say, they more often than not will present to hospital anyway, so they're not often coming into the clinic. Really.
True, and so the tricky one is the isolated posterior malleolar fracture. So we have occasional patient that just has a break at the back of the tibia, and people focus on the break, whether the break's going to heal, and the break's going to heal without, unless it's really big. Typically it's going to heal, and I think when patients come to see me, I think they're really worried about whether the break's going to heal, and think that I'm worried about whether the break's going to heal. I'm actually really worried about the syndesmosis. Because I find it hard, unless it's a real just a direct mechanism to the back, I find it hard to get that injury without some level of rotation. And more often than not with those ones, I'll have MRI them to look at the ligaments, because the reason is that the posterior malleolus will likely be attached to that PITFL. So if that's broken but the ligament's intact, it's almost like the ligament floating free. It's attached to a broken piece of bone. Okay, and so then if the break if the AITFL, so the one at the front's gone, usually by rights the one in the middle has gone as well, and then technically that's a 3 ligament injury.
Yeah.
Now, if everything stays exactly where it should stay, as in it doesn't move, then the patient might be all right. As in, you keep them pretty still, and the fracture at the back heals, which means ultimately that PITFL at the back's going to be okay. The AITFL scar up in time, they might be all right, but you're taking a risk that fibula can move in the meantime. And then the other thing is that there's another ligament, there's the middle one. And I've just spent, a bit of time saying to you guys, well, if I go to the front and the middle, it probably remains unstable in some cases. Okay. So I've got a bent on operating on those, but I've actually had a few that have seen other surgeons that have not been operated on. But that's just something, that's probably one other injury that if it's isolated to the back there, that probably needs another opinion to make that decision, basically, right? Because then the surgeons then taking, if they want to treat, the surgeon was treating non-operative, that's okay. And I don't think anyone can really criticise them for that. And they're taking that risk on. And as long as they've explained that to the patient, that's okay. That's fine. So, when I'm talking to I tell them what I'm worried about, reason why why I think it's necessary. But I will say that with people that will treat this non-operatively, and if they choose to go down that non-operative path, that's absolutely fine, as long as they're aware of there might be a little bit of risk with that, basically, so.
Yeah. Do these injuries, like, does it just mean it's more force? Like, when do you typically see these injuries in regards to how they occur? Like, is it always with contact sport, the more severe ones and more serious ones?
Probably majority, maybe about 7 out of 10. But most of the guys, they're typically men, funnily enough. I guess rugby league are dominating. I don't see them much in netball. Strangely, I think you just do your ACL in netball. I think that's usually what you do. But but actually, this is most supposed to be ACL of the ankle. Apparently, that's the latest. Thought. I know it's pretty cool.
That's a good title for the podcast.
Yeah.
Probably a lot quicker,
it's better than saying,
wise.
Yeah.
It's sort of like saying, well, because ankle sprains are a bit boring. Like, we're just talking about sprains.
And it pricks your ears up.
ACL.
So much about ACLs.
That's how it's going to be our podcast title, I reckon.
I just said that. Literally just 20 seconds ago. You're going to listen to him, that's why. I got nothing to say.
I zone out when you speak.
Sorry, mate, what were you asking me? So, typically high energy. Typically they're. I find they're typically not in sport. I've had one lady who tripped putting the washing out and stuff, and so that happen in other scenarios. But typically, and like for instance, where we're at now, coming into summer, the syndesmosis just seem to go away. They go into hibernation over sort of Christmas, and then here in Australia anyway, and then they come back out. I think I was whinging to Justin. Actually, I think I was talking to Justin earlier in the year. I was like, "Oh, mate, I'm really sorry. I've got all this general foot and ankle work, which I've given you a lot of referrals on for, which I'm sure he was complaining about, right?" And I was like, "Mate, I'm sorry. My sports injuries are dried up. Like, where they are, it's like April, March. They should be starting to come back again now. Like, where are they?" And lo and behold, in May, they just hit with a bang. So, I think they're very much associated with sport, and so I think they'll disappear for a while now. Yeah, and come back in.
Yeah, summer's the time to plan a heel pain and plan a fasciitis. That's your favourite to see, isn't it?
Oh, mate, I love it.
Bunions.
About
the French one.
Oh yeah.
Oh yeah. Sorry. Yeah. So Maisonneuve, I don't know who Maisonneuve is. If I wanted to sound really smart, I would have looked that up beforehand. But you guys might think I went up. But I'm sure it was French. But basically, it's sort of like a much higher Weber C. So it's usually mid shaft or proximal shaft of the fibula, and it's one of those ones that really tricks everybody because patient will be sore up high. That's where they're tender. They actually do have some tenderness in the ankle, but no one looks at it. And the imaging is all about the fibula break. And then they think, well, okay, so they've just got a fibula break off. You go and walk on it. The patient is still sore 6-8 weeks down the track. So basically, that injury is a rotational force to the ankle that's transmitted through the syndesmosis up through the interosseous membrane and exits out the fibula. Okay, right. So you get a fibula break. The fibula break is not a problem. It will heal. The problem is this big syndesmosis injury that's occurred further down the ankle and through the interosseous membrane. And so those need to be treated operatively with some sort of stabilization to the syndesmosis, or they're very unlikely to get better. And so you may actually see, so I've had a couple of referrals where that's just been purely a posterior malleolar fracture as presented. And funnily enough, they had the high fibular fracture with it. So they really did have a big rotational force. And I've had other people that have just had an ankle x-ray, weight bearing, where the clear space on that medial side has been really wide. And the emergency guys have run me really perplexed. They're like, but there's no fracture. There's no fibular fracture. Why is the talus moved and stuff? I was like, oh, if you felt further up, like near the knee somewhere, like a bit further down from the knee, and they come back and be like, oh yeah, it's really sore. And you do an x-ray further up, and they're like, yeah, there's a fracture there. Like, yep, there's something called major nerve injury. So it's not that well known. All orthopedic surgeons know about it, and so any orthopedic surgeon should be able to pick that up. But that's just one thing to be aware of. If the patient's got sort of mid-shaft fibular pain or pain up in the knee, just check the ankle to see if it's sore. Basically, that's all you need to do. Because if they're sore, then you need to worry about that injury. That's all.
Yeah, cool.
Yeah. Did you have any more questions?
No, I'm okay now.
That was good. Yeah. That was awesome. Yeah, that was really good. Now I've got a couple of listener questions. So
should we do them rapid fire again, like we did last time?
Well,
rapid fire.
I don't think the first one probably not. And I mean, I'm really. I said this from the start. I'm always excited for these episodes, but I'm really excited to clip your answer to this question because it's a bit of a hot. I mean, it's always a hot topic in podiatry, but there has definitely been a bit of a movement lately, and I guess there's always the movement of the barefoot minimalist, wearing wide fitting shoes with low drop, prevent all foot pain, and, anyone with any toe deformity or bunion deformity or ankle fusion, everyone just needs minimalist shoes. So one thing that's been thrown around lately, and this was the listener question, was, are bunions reversible non-operatively? And we're talking probably the moderate to severe ones, in the sense of strengthening up the muscles on the inside, because I'm under the impression the physiology of the tissue would change within the joint capsule. So yeah, what have you got to say about that?
Well, actually, before you clip it, I'd be interested to see what you think of that, Blake. You reckon they're reversible?
No, God, no. It's thinking constructing the abductor hallucination, be able to pull that big toe around. Like, I'm under the impression those structures are tightened and they've changed their physiology.
I wish they were reversible. Like, that'd be great, right? Because the surgery's got a percentage of recurrence rate. So it'd be great if we could treat it non-operatively just by strengthening on the other side. But I guess we don't know the exact pathophysiology of like why they, or sorry, pathogenesis of bunions. We don't really know exactly. Like, I'm sure you read some stuff where there's populations that don't wear a lot of shoes that don't seem to have bunions, but just saying it's shoe wear that's the cause is not correct either. There's a strong genetic component as well. So we presume what happens is something causes that metatarsal to go into sort of more varus, basically. Okay. And what that changes the line of pull to all those structures that usually run straight, so that EHL, FHL, all of a sudden they're running in a position where it's increasing the deformity. So rather than running straight up and down the toe, if the phalanx is starting to point towards the little toe, then if the EHL and FHL are attached, to the phalanges more distally, they're actually going to increase the deformity every time they pull. Like, does that make sense? Like, if you rather than a straight. So, and then the other thing is, so the lateral structures start to become tight, and the medial structures become loose or weak, or the tissue. So for instance, as surgeons, we're taught that we can't rely. Like, typically, previously, they just tried to really tighten the tissue on the medial side of the bunion, and that looks good when the patient's asleep. Like, it looks really good. Like, but then if you just did that 5-6 weeks later, their bunion will be back to where it was before, and I'll say, well, did you do anything? So when we're doing surgery, we're actually very much relying on the bony corrections more so than anything we do with the tissues. So I wish they were reversible without surgery. Like, I really do. Like, I think for the surgery you have to go to get them corrected, it'd be great if we had a good non-operative treatment that reversed it. But there isn't one there. There's not, and I can't see how any of them would work, to be honest. Once the tissue, you're right, tissues they get very contracted on that lateral side. Like, we have to release them with a knife surgically, a scalpel, right? So you can dry needle them, you can pull them, you can do whatever. Unfortunately, it's not even that easy to use with a scalpel. So I wish they were reversible. I really do. Like bunions are not a bad operation, but there are other operations I enjoy doing much more. Like, it's part of my thing. But so I wish I could offer patients for any forefoot surgery that not like some really good reversible non-operative management, but it's more about managing symptoms with non-operative management for bunions. We can't reverse it once it's there, even in a mild deformity. We can't reverse it with non-operative management. I do wish that was the case. That would be great, but we can't. Yeah, unfortunately.
And I've read, and I saw you mentioned before, and I have read that there is a pretty big, or we think that there's somewhat of a genetic component to it. So my impression is, and the patients that I see, I definitely don't, in the sense of there's no symptoms, and we usually see them for an opinion in regards to what can I do to prevent it. We had the long conversation to say that it follows its own timeline and that kind of thing. But because there is that genetic component, using orthotics in the presence of no symptoms isn't a preventable measure. Would you agree with that?
I would. I would say that applies to a lot of things, unfortunately. I think there's this sort of bad thing that surgeons just don't like I like orthotics, so I refer for a lot of orthotics. But typically you're treating patients with pain. They're trying to offload areas that are painful or inflamed, and as you know, Blake, doesn't always work. And things you think mechanically should make massive differences sometimes don't. I don't really buy into orthotics as a preventative measure. I know that's from a podiatry point of view, that can be somewhat controversial, but surgeons don't really have a bent against it. No, I know. We don't really have a bent against it. We just want to do things that we think actually work. And if we had good evidence to say, well, that's a preventative measure that's going to make a big difference, then we'll be all for it. But particularly at bunions, you can put it in your 15-year-old daughter, but you'd be wasting your money, if I'm being honest. So that would be my opinion on it. I wouldn't recommend that to my family. I truly believe that. But if it made a difference, I would. If I had good evidence, I would. But I don't think so. It's a biomechanical problem, but it's not one that you can prevent with an orthotic. I would think no. I don't have any evidence for that at all. You can just stick a toe spacer in them for 30 years and see how that makes a difference. But I don't. Yeah, but I don't. No, I don't. I think you can't unfortunately beat the genetics in those people, and the biomechanics of that problem will overcome any orthotic probably you've got that a patient can comfortably wear. So.
And then our next question, which again very, very hard to answer, but how soon do you think that kind of neuritis bursa complex in the forefoot should be injected? And this is obviously another podiatrist question, which it's hard to answer, I know.
No, it's hard to answer. I mean, I listened to your podcast on the London foot and ankle surgeon. I always forget his name. I forgot the last one, but and I remember him saying that. Like for instance, he's not super keen on injections and things like Morton's uroma. He doesn't typically inject. I think it depends on what you're looking for. He did make a comment. He's like, well, if you've got a burst that's inflamed or Morton's uroma, if there's something that's fueling that or causing that, that's not a problem on its own. And I tend to agree with that state, particularly maybe not so much in Morton's uroma, but for things like bursitis, I think that's a sign of an underlying problem, either mechanical or something else, that's driving the bursa to be inflamed more so than the bursa just going off on its own. Like when you're talking to Nikki, it's not like with heel pain, Achilles tendonitis, or with hamstrings. It's usually in conjunction with some other problem. So, like for instance, so I think normally I can't think of the last time I arranged for an got an injection to a bursa. I've definitely done plenty of Morton's uromas, but not the bursa itself.
Yeah.
No, I know that's much more common. Like lots of people order it for bursas. I much prefer to rely on mechanical offloading first than looking at injections. And the problem with injecting around the bursa is you're worried about causing other issues like issues with the plantar plate, you can cause skin issues with steroid, that sort of stuff. It's not. I don't typically. So I guess Morton's uroma is a little bit different. I'll speak that in a sec. For a bursa, I'd much rather look at mechanics of the foot. Is there something I can offload? I need like a pre-bent dome. Where's the pain? Is it a plantar plate tear? Do they need more imaging or something like that? Is there clinical deformity somewhere? That's what I prefer to treat. I try and do that with addition of an anti-inflammatory, provided there's no contraindications. And I typically leave my injections as a mix of treatment and diagnosis. And what I mean by that is I always want to know from the patient what benefit they got in the first few hours from a local anesthetic, because that helps me to work out if the area that's injected is the pain generating area. And so the bursa will be sore, but on its own, it's unlikely to be the primary reason for their pain, if you know what I mean. So I much prefer to say be injecting a joint or something else around there that or an interspace where I'm worried about a Morton's uroma or something like that. Yeah. If it matches up clinically. So when is a hard question, because it depends on the pathology, but I always hold off as long as possible. I would have tried everything else basically is the answer. I would have tried anti-inflammatories, or would have got imaging such as an X-ray minimum, possibly an MRI if I'm worried about, say, plantar plate tear something. But definitely I would have tried offloading with a podiatrist before going down that path. And I possibly would have got if a podiatrist, maybe if you're thinking about injecting, I'd probably get another opinion from GPs, well, sports doc, orthopedic surgeon, something like that. And then Morton's is a slightly different beast. I do think Morton's neuroma, yes, they've probably been there for a while and all of a sudden become inflamed. But I've found it, I don't know what you found, Blake, offloading it can be variable. I know the advice is wider shoes definitely helps, but not everybody. So typically with the injection for them, I'm actually really asking for it from a diagnostic point of view. I basically say to the patient, look, we're going to inject next to the Morton's neuroma. You might get some benefit from the steroid. Maybe. Basically, the way I see it is flip of the coin. If you get some improvement from the steroid, fantastic, that's a bonus. But what I want to know, number one, is that definitely causing your pain? Two, if I take it out, is that going to fix the problem? And so if they inject local anesthetic next to the nerve and the patient feels heaps better for that small window of time with the local anesthetic, that tells me usually that if I go take out that nerve, probably they're going to feel better. And if they come back to me and say, oh, no, I'm feeling really good now, it's been 3 weeks, steroids still working, I say, well, that's fine. Why don't we just let it go for the moment and see how things run? And if you get 3 or 6 months down the track, you might be able to inject it again. But if it only lasts a week or two, then probably we're looking at needing to do something to operate to your foot. So I think once with the Morton's neuroma, though, I'd probably try offloading it in wide shoe wear first. And then if that's doing nothing, then probably an injection for that is reasonable. But like I said, I do it for slightly different reasons. I do it less for treatment, more for diagnosis, with the bonus if the treatment works, basically. Yeah.
That's a good answer.
Yeah, good. Mate, if you start recommending wide shoes and Met Domes, I'll have to retire. That's bloody 4 years of my uni course.
Yeah, right. Yeah, right. So,
no,
I don't know. Like I don't. Patients sit there and they're like, I have one patient. A lot of patients just just want it out. Funnily enough, I was like, so you want to try something else? Like we try this and that. Like, oh, does it really work? I was like, well, in some cases, they're like, no, just take it out.
Take it out.
And I had one. And so then I started to broaching the subject of surgery more quickly with some patients. I had one lady just like, what? You want to take it out? Like, I only just met you. And I was like, yeah, and I was like, that's okay. I don't know. There's definitely there's other things we talked about we can try, but I've had a lot of patients recently that just think if it's only maybe going to work, they don't want to do it. It's just like, I don't know, I definitely don't want surgery. I was like, yeah, that's fine.
Yeah,
so,
good.
You sort of speak, which is good. No, it was the wrong conversation from my point of view, right? So I just sort of been lulled into this sense of I had a few 4 or 5 patients in a row that really didn't want to listen about the non-operative, which is what usually I'll talk about, but they just didn't really want to hear it. And so I changed tack wrongly, probably in that regard. It was a good wake up call to switch back. So yeah, but yeah.
Awesome, mate. Well, thank you so much for coming on. I hope you enjoy the rest of your day. You're operating today and then you've got 2 days off. Is that right? So you have a bit of time off?
A couple of days off. Technically I'm on call, but we'll just see what grand final weekend actually, funnily enough, is usually less. Well, Sunday night should be less busy.
If the Eels win, it should be busy. But if Penrith win, if the Eels win, I don't think it will be as busy. But if they lose, I don't know. I don't know about the Parramatta.
Don't know. I think the Eels fans are used to losing, though. So
yeah, it's just normal for them. Normal weekend.
Just normal for them. You should be able to take it pretty well. They had a lot of disappointment for a long time. So if they lose, they'll be all right. I'll just think back if they're wherever they came from.
Yeah, hopefully in a year we'll be having no, Knights supporter through and through. I was saying hopefully in a year we're having the same conversation and we're talking about the Knights playing in the grand final, but we'll see.
Yeah, mate. Well, mate, they're in the final, right? The girls I've met some of the girls. They are absolutely fantastic people.
Yeah, they're great.
Honestly, I cannot speak more highly of the ones I've met. I honestly hope they win because they're a fantastic group of people and a great team. So I really hope they win.
Yeah. Awesome, mate. Thank you so much for coming on. Cool. Enjoy the rest of your weekend.
Thanks, guys. Have a great long weekend. See ya.